Hello and welcome everybody. I'll just give us maybe one more minute and then we'll get started. Thank you for joining us today for another ASRP Exchange presentation. This will be the same length as previous presentations. It will be about 1 hour from noon Eastern Standard Time to 1 p.m. Okay, I think I'll just jump right in. So good afternoon, everyone. My name is Caitlin Jaggers. I am the research lead for the Research Knowledge Translation and Exchange team at the Alzheimer Society of Canada. The Alzheimer Society of Canada is very pleased to welcome you to another ASRP Exchange presentation that is being offered through our provincial support program. This series has been developed to feature Alzheimer Society Research Program recipients who have completed their funding and who will speak to the outcomes of their supported research while addressing how their results have and will continue to impact people with lived experience. Also joining us today is Daisy Couture from the Alzheimer Society of British Columbia, who will join me in moderating the question and answer period following today's presentation. I would like to start off today's webinar by going through the agenda presented here, and then we will pass it over to our presenter, Mr. Jordan Ali. Before we begin, please note this webinar is estimated to be under 1 hour in length and is being recorded, but that only the video and audio of the presenters is captured during this recording. The presentation recording, in addition to the PowerPoint slides in PDF form, will be made available on Connection for Alzheimer Society staff, as well as on the Alzheimer Society of Canada website on our new ASRP Exchange webpage following today's webinar. Today's webinar is presented by Mr. Jordan Ali and is being offered as one of the ASRP Exchange webinars within the Provincial Support Program Meet the Researchers series. We are so pleased to have Mr. Ali with us today to present his project, A Qualitative Characterization of Concerns, Complaints, and Experiential Predictors of Objective Cognitive Decline in Older Adults with Subjective Cognitive Decline. This project was funded by the Alzheimer Society Research Program starting in July of 2017, with project completion in June of 2020. Jordan Ali is a doctoral candidate in clinical psychology, neuropsychology at the University of Victoria and is currently completing his predoctoral residency at the London Clinical Psychology Residency Consortium. He has received numerous accolades for his research and community engagement and was the recipient of the 2017 Alzheimer Society Research Program Mr. and Mrs. Albert Spatz Doctoral Award. Mr. Ali has extensive experience working with older adults experiencing cognitive, physical, and functional difficulties due to dementia, stroke, and other issues of older adulthood. Outside of the clinic, his research relates to cognitive aging and identifying the potential earliest signs of dementia and other pathological cognitive conditions of older age. Mr. Ali's work frequently spotlights the lived experiences of older adults, as this source is unique and is often overlooked in clinical research. At the end of today's presentation, Daisy and I will be moderating a short question and answer period. Please use the Zoom chat box feature if you have any comments you would like to make or questions you would like to pose during the presentation. Please note, however, we will hold off on asking these questions to our presenter until the presentation has concluded. Without further ado, please join me in welcoming Mr. Jordan Ali.
Hi, everyone. And thank you for the lovely introduction. So I suppose I will share my screen now. Let's hope that technology likes us. All right, and are all of you seeing this lovely picture of the west coast of Canada here? Yeah, okay. All right. All right, so let me jump right in because I can't really see any of you. So thanks everyone for being here today. It is an honor to present my PhD work to you, to discuss that with you, at least a part of it, because we actually are basing a number of different studies on this larger project. So as part of my PhD, I conducted several studies aimed at identifying specific quantitative and qualitative risk indicators for pathological cognitive decline in healthy older adults. So to be clear, we're not studying dementia per se or dementia directly, but rather we're studying a few conditions that have been proposed as potential risk indicators for the eventual development of dementia. There we go. Okay. So in recent years, clinical research and intervention efforts have veered away from trying to change the course of Alzheimer's disease and other dementias once they're already firmly established. Instead, increasing attention has been paid to earlier and earlier developmental stages of pathological cognitive decline that may be more amenable to change. To optimize early detection and effective intervention, a key consideration may be identifying a stage of decline before objective impairments become apparent. Subjective cognitive decline may represent just such a stage, and just because it's a mouthful, we call this SCD. So individuals with SCD report experiencing cognitive declines that cause them concern. However, upon standardized testing, these individuals perform soundly within normal limits. Now, it may seem a simple matter to conclude that each of these individuals are simply overly worried about perfectly normal age-related changes. However, there is growing evidence to suggest that a large percentage of those reporting SCD will go on to develop objective cognitive declines in due course. This suggests that those with SCD may be plugging into unique insights about their well-being that perhaps our more typical methods of assessment are overlooking. So the question then is, if SCD is so predictive of objective cognitive impairment, why has it not been widely adopted as a dementia risk marker? Unfortunately, despite the promise of SCD, several challenges have made it difficult to leverage effectively for clinical screening. Okay. So first, a number of different psychosocial, somatic, and neurological conditions may impact SCD. That is, whether one complains at all and what about. As a result, it's difficult to determine exactly when or for whom SCD may be suggestive of incipient cognitive decline. Given its somewhat abstract nature, SCD has also been conceptualized in a variety of ways, with some definitions focusing more on specific cognitive domains, while others focus on the number of complaints one has, or even the degree of distress experienced by someone with complaints. This variability has led to a diverse literature that's been difficult to synthesize effectively. So essentially, it's difficult to know exactly which version of SCD is the most clinically useful, and again, for whom. A final but important reason our accumulated knowledge has failed to coalesce into a gold standard screening practice is a lack of integration across research methods. Now, we've explored SCD through standardized cognitive testing, through biomedical imaging, and through qualitative interviewing. And each of these methods has provided some degree of unique insight. However, few, if any, studies have merged these different sources of information. This is unfortunate, as each of these approaches alone have failed to provide a clear answer to the question, when is SCD risky? Thus, drawing from various sources of information and reconciling diverse data, what we call a mixed methods approach, may provide a more holistic view of SCD and SCD-related risk as we move forward. So we had a number of sort of overall research aims for the project at large. So the first was to examine the specific characteristics of healthy older adults who may be at increased risk of developing objective cognitive decline in the future. And of course, that's based on our proposed indicators of SCD and subtle CD. Let's talk about it in a moment. Next, we hope to create a bridge between various sources of clinical information. That is, to identify areas of convergence and divergence between quantitative, qualitative, and genetic data. And then we hope to identify potential key items or key considerations that may lend themselves to early and accurate and reliable detection of dementia risk. So essentially, we're aiming to solve the world's problems in one project. Okay, so we had three main variables of interest throughout each of our studies. Of course, our first was SCD. We used the SCD plus criteria proposed by Jessen et al. In 2014. And we assessed SCD using a single question, querying whether participants were concerned about any potential perceived cognitive changes. So that is, we weren't just asking if things have changed, but whether the things that had changed were causing people concern about their cognitive health. Our next variable of interest was subtle cognitive decline, what we've called subtle CD. This is a more objective measure of potential cognitive change. We amended the criteria created by Edmonds et al. In 2015 to be more suitable to our larger and really more robust neuropsychological battery. So with subtle CD, essentially what it is those with lower than expected, but still within the broadly normal range of cognitive performance are considered to have subtle CD. So they're not frankly impaired, but they are just lower than we would expect. Finally, we used saliva samples and qPCR analysis to determine the presence or absence of the ApoE4 genotype, as this specific genetic marker has been linked to increased risk of dementia. So our participants were 65 years of age or older, lived independently in the community, and had no history of neurological issue like stroke or epilepsy or anything like that. Eligible participants performed within normal limits on 2 cognitive screening measures, one of which was administered over the phone. Our total sample consisted of 65 participants overall, and the breakdown per group is provided on our lovely slide. Notably, our sample was almost entirely comprised of women and almost entirely comprised of retired academics and professionals. So a pretty select and pretty high functioning group. Now we collected our data in various ways over various days. So we began with a telephone eligibility screening that included a number of demographic items, as well as a cognitive screener that is developed to be administered over the phone. On a subsequent day, we conducted our neuropsychological assessment. Our test battery was designed to align for the most part with the ADNI dataset, which is a large-scale Alzheimer's disease study. So we tested things like memory and attention and language and basically a little bit of every cognitive domain we could think of. On another day, we conducted a one-on-one interview regarding our participants' experiences of cognitive change with age and any concerns that they may have with any of that. And then following this, we collected saliva samples that we used for our ApoE4 genotype analysis. Finally, the transcripts from the qualitative interviews were typed up and summarized, and we sent that to our participants. Then we followed up with a telephone conversation just to make sure that our understanding and our summary was actually reflective of their lived experience. And this step is called a member check in the qualitative research world, just to make sure that we're not misrepresenting anyone. Okay, so I'll go over 2 studies because going over many more will take us into the 2-hour mark, and I'm sure you all have other things to do today. So for study 1, we had 2 aims. First, to see which factors may contribute most to SCD endorsement, and then to determine which factors contribute to subtle CD, which again is our objective measure of potential cognitive change. Now, chief among these, we were curious to what extent SCD and ApoE genotype really predict objective changes in cognitive performance. So to figure this out, we conducted binary logistic regression analyses with forward entry. And as you can see, we included a large number of variables, a large number of potential predictors. And that's just because we're at the earliest stages of this research. It's still exploratory, and we really wanted to know whether there were any demographic or other psychosocial characteristics that might lend themselves to somebody endorsing SCD, or that might give us insight into whether somebody is struggling cognitively. So I'll start with some bad news, I suppose. Unfortunately, after our qPCR analysis was completed, it became clear that our sample for ApoE4 positive participants was too low to perform meaningful statistical analyses. Over our entire sample, we only had 11 people who actually had the ApoE4 gene. So as such, it was decided to run our models and all subsequent analyses without that genetic piece. So that was unfortunate. However, I'd like to think that the rest of what we did is still really interesting. So let me show you that now. So with regard to our predictive model for subtle CD, which again is that objective piece, our model improved classification accuracy from 66% to 78.5%. That is, when the following factors were accounted for, we were approximately 12% more accurate in our ability to predict who may be showing potential early signs of objective cognitive decline, or at least so far as subtle CD could tell us that. Interestingly, when we look at the specific items included in this model, we see that some of the things that we may have expected are actually missing. Neither memory, nor word finding, nor orientation were identified as significant contributors to subtle CD. Importantly, SCD was not identified as a significant predictor either. Instead, we see that decreased planning ability relative to same-aged peers was the greatest independent contributor to subtle CD. And planning ability is something that we would consider an executive functioning change. It has nothing to do with memory or anything like that. So for those of you who haven't heard this term before, executive functions are high horsepower thinking abilities that include things like planning, reasoning, adjusting, self-monitoring, things like that. There's also a thinking ability called working memory, which is essentially being able to keep information in mind and manipulate it, like, I guess, mentally figuring out a tip or something like that. That's also an executive functioning ability. So these types of executive functioning abilities, these thinking abilities, require finely tuned coordination across various brain networks. And as a result, they can be very sensitive to any disruption in our system. So finding an executive change here is interesting, and it suggests that changes in executive functioning may arise before memory changes. However, since this is all based on self-report data, it's also possible that individuals experiencing subtle CD may simply have been more comfortable endorsing executive functioning changes than other changes that they associate more with dementia, like changes in memory or changes in orientation. So it's kind of hard to tease that apart. Okay. So following declines in planning, the next greatest predictors of subtle CD were reporting fewer depression symptoms, which is odd, and reporting more anxiety about physiological change and disability. Together, these may indicate a primary concern with functional capability and independence. And even more than that, this may suggest an investment in maintaining the appearance of capability and independence. To the extent that depressive symptoms are viewed as maybe a personal failing or a moral weakness or something like that, participants may have shied away from endorsing them. Physical concerns, on the other hand, may have been more acceptable, more concrete, more external to one's character, therefore making them more easily acknowledged. So it's a possibility. So overall, our subtle CD-prone profile appears to center around executive functioning changes, concerns about capability and independence, and possibly distancing from the feared outcome of dementia. With regard to our SCD predictive model, so now that subjective piece, our final model increased our classification accuracy from 66.2% to 76.9%. Our most reliable and significant predictors were fear of aging and age-related losses, self-endorsed word-finding difficulties, and cognitive change overall, which was the degree to which people felt their cognitive abilities had declined. Now, these all seem fairly consistent with what we would consider cognitive concern. Things are changing for the worse, and I don't like it. It worries me. Again, a number of factors that we may have expected are absent in this model. So subtle CD was never identified as a major contributor to SCD, suggesting that these two constructs reflect almost completely separate sources of potential risk. Moreover, our SCD model tended not to include depressive symptomology, loneliness, or cognitive functioning relative to peers, which are all things that we typically see in the research. Our SCD profile then appeared to load almost solely on the perception of cognitive decline and concerns about potential future changes as one ages. So comparing our subtle CD and SCD profiles, it becomes clear that these two constructs appear to reflect quite different things. Concerns about cognitive functioning do not appear to reflect actual cognitive functioning declines. Where SCD appears to reflect a greater degree of cognitive concern, subtle CD appears to reflect more functional concerns. Further, there's the possibility that those with SCD and subtle CD may be differently motivated. While those with SCD are often faced with trying to have their fears validated, those with subtle CD may seek the exact opposite and hope to have their greatest concerns invalidated. Okay, so in sum, SCD and subtle CD represented unique sources of potential risk, and contributors to each were distinct. Where SCD appeared to align more with attunement to changes and anxiety about cognitive declines, subtle CD appeared to reflect more concrete concerns about independence. Additionally, it's possible that those demonstrating subtle CD may engage in some degree of defensive responding and may be unlikely to endorse concerns or changes in cognitive areas that they associate closely with dementia. Finally, and importantly, our results suggest that self-reported changes in memory may not be an accurate predictor of risk at the earliest stages of potential cognitive decline. Memory changes may not be readily reported, noticed, or even manifested until later in the cognitive decline process. Instead, executive functioning may be more sensitive to the subtle perturbations in neurological functioning that might occur earliest on in the pathological process. Okay. So our next study, there we go. Our next study focused more on determining which qualitative or lived experiences arise most frequently for older adults. And even more importantly, how the endorsement of specific qualitative experiences may relate to the potential risk of SCD and subtle CD. So we conducted a content analysis on our transcribed interview data. Participants' experiences with aging and cognition were coded according to item content, categorized according to cognitive or functional domain, and then themed according to overarching topics. Now, given our low sample size overall, our primary outcomes are based on MANOVA analyses of the category level data. So we didn't have enough people endorsing any one specific experience, but we did have a number of people endorsing things within the same category. So it gave us a little bit more statistical power to do it that way. So this is my, my lovely diagram here. So we were not looking at each specific item or each specific symptom. We were looking at categories of symptoms or experiences. So our analyses found no significant effects of SCD or subtle CD on category level endorsements overall. And this could very well be because our sample was so small. However, given the exploratory nature of the study, we felt it prudent to continue exploring the between subjects effects in any case. So after coding and sorting all of our qualitative data, two major themes became apparent. That was cognitive change and behavioral change. So for theme one, cognitive change, all of our data consisted of categories of experiences related to declines in thinking abilities. Now we found few significant effects, but what we did find appeared to relate uniquely to executive functioning again. Specifically, those with SCD tended to endorse more executive functioning declines than those without SCD, and this appeared to drive an overall increase in the endorsement of cognitive change. Interestingly, those with subtle CD demonstrated an opposite effect. Subtle CD, at least during conversation, was associated with significantly fewer reported executive functioning declines. Again, we see similarly counterintuitive findings for those with subtle CD, similar to our previous study, where they endorsed more executive functioning change before on questionnaires. They now endorsed fewer during interviews. It's possible that those with subtle CD may be more reticent to disclose cognitive change experiences, even if they are noticed, perhaps in order to ward against the possible diagnosis of dementia or just any questions about their competence. Our second theme, behavioral change, comprised categories of compensatory strategies in response to cognitive changes. So unexpectedly, we only found significant effects of SCD on behavioral change endorsement. No effects were found for subtle CD, which again is our objectively lower functioning group. Those with SCD were more likely to engage in strategies related to reviewing, repeating, or rehearsing material relative to those without SCD. And this is often done explicitly to ensure that information remained in working memory, which once again is one of those executive functions. There's also a trending increase for those with SCD to engage more in advanced preparations for the possibility of dementia. So this included things like preparing advanced directives, researching medical assistance in dying, and conducting independent study of dementia-related content. Again, subtle CD, our objectively lower functioning group, demonstrated no effect on the endorsement of behavioral changes or compensatory strategies. This unexpected difference between SCD and subtle CD may have resulted from several things. It's possible, again, that those with subtle CD may be less open to disclosing concrete changes in their behavior for fear that it may suggest a degree of incompetence or pathology that they're unwilling to acknowledge or consider. Alternatively, it's possible that concern is the key determinant in whether behavioral changes are undertaken or even noticed. The fact that increasing exposure strategies were specifically endorsed is also of interest, these working memory strategies. It's possible that working memory is more of an issue, but then that wouldn't explain why there is such a difference in the groups. One possibility is that the appeal of these strategies, these increasing exposure strategies of rehearsal and reviewing things multiple times, is that they're more covert. They can be implemented invisibly without people around you seeing and without anyone really raising too many questions about your ability level. So in sum, SCD tended to increase the endorsement of executive functioning changes, while subtle CD counterintuitively decreased endorsement of the same. Reinforcing the findings from our earlier study, it's possible that this divergence reflects a difference in the degree of concrete threat experienced by those with SCD and subtle CD. While subtle CD was not associated with the endorsement of any compensatory strategies, those with SCD tended to endorse strategies related to optimizing working memory and cognitive processing. Taken together, these results suggest that executive functioning, again, is central in the early subclinical phase of potential pathological cognitive decline. The unique endorsement of executive functioning change and executive functioning related strategies among those with SCD suggests that declines in this domain may be experienced as most worrisome, maybe most unexpected, or most apparent in the early preclinical phase. Okay, so overall, a common thread throughout our studies was that SCD and subtle CD represent distinct sources of potential risk. SCD was found to relate most closely to anxiety and perceived cognitive decline. While it remains possible that extremely early changes in cognition may underlie SCD, it's difficult to determine given our data. At best, we can say that SCD was not strongly associated with subtle CD, which is our objective lower functioning criterion. This point is important going forward. There's a natural assumption of a linear developmental trajectory throughout much of the SCD and objective cognitive decline literature. There's this assumption that cognitive change starts with SCD, develops into subtle cognitive decline, and then eventually develops into dementia for those who are going to get dementia. Our findings suggest that this may be misguided. While those who develop objective cognitive decline may report SCD at some point, our findings suggest that at least some may demonstrate subtle CD without reporting concerns. Future studies would do well to treat SCD and subtle CD as distinct and potentially interacting risk factors, rather than the progression of the same pathology. Another common thread throughout our studies was a tendency for those with subtle CD to report fewer cognitive changes, fewer compensatory strategies, and fewer mood symptoms. In other words, those who demonstrated measurably lower cognitive performance denied experiencing many of the known risk factors for cognitive decline. It's possible that for those experiencing subtle CD or more objective cognitive declines, the threat of dementia feels concrete, imminent, and threatening. As a result, these individuals may be more invested in displaying their competence and independence by underreporting some of their changes or challenges. Clinically speaking, this potential bias is important. It suggests that self-report may become less reliable as individuals experience more cognitive changes. Clinicians may be well advised to seek corroborating information from friends and family members in these cases. Further, where dementia threat is salient for individuals, questionnaires may be more likely to elicit open disclosure. Finally, executive functioning may provide us more insight into early cognitive changes and associated risk than memory declines. Not only may executive changes take place earlier in the pathological decline process, but older adults may disclose said changes more openly due to the ambiguous relationship between executive functions and dementia. The other side of that, of course, is that fluid reasoning or executive functioning changes are expected to decline. Executive functioning is expected to decline as people age naturally. As we get older, all of our executive functioning gets worse. So that's true for everyone. So future research would really benefit from focusing on differentiating risky executive changes from more normal executive changes as possible. Okay, so every study has limitations and ours was no different. So some of the major limitations are as follow. A major limitation for us was our small sample. It was difficult to recruit participants and only a fraction of those screened were found to be eligible. Our small sample made it impossible to include ApoE genotype in our analyses in any meaningful way. Likewise, it led our statistical comparisons to be underpowered. So we definitely need to do some replication in order to really reinforce, substantiate what we found. An interesting and unexpected limitation was that our sample demonstrated a unique interpretation of SED, quite different from what's common in our SED research. Rather than expressing concern that any current cognitive changes may be problematic, almost all of our SED participants reported abstract concerns that dementia may develop one day. They did not see themselves as being at any greater risk than any other older adult at the moment, and often reported themselves to be functioning better than their peers. As a result, our findings may be difficult to generalize to other samples with a more pathological interpretation of their cognitive concerns. Another challenge was that our conceptualization of subtle CD was theoretically driven. Now, although our definition of subtle CD was based on Edmonds et al. In 2015, this is still a relatively new construct. So further work is required to determine whether Edmonds' criteria or ours truly indicate risky cognitive changes. The final limitation I'll present today is the self-selected nature of our sample. Our sample represented a very distinct group of people. Our participants were highly educated and relatively confident in their cognitive functioning. Further, our sample is incredibly homogeneous across ethnic and socioeconomic lines. Indeed, many of our participants stated that they joined the study precisely because they felt that they were functioning better than their peers. And some went on to share that acquaintances who were more concerned about their cognitive functioning had refused to join the study out of fear that they may be diagnosed or otherwise have their fears about dementia reinforced. So all this to say that our findings may not be entirely generalizable to samples with more diverse representation or a greater degree of current cognitive concern. So in future, we would encourage more large-scale studies to include and compare quantitative, qualitative, and physiological data. Not only would this be meaningful cross-sectionally, so in that moment, but longitudinal studies over time may clarify how these various sources of data relate to each other, how they change with age, and how they change as cognitive decline progresses. Further, to gain a richer understanding of which lived experiences may be most clinically useful and when, it may be fruitful to compare qualitative data across groups with varying levels of cognitive risk and decline. So for example, comparing the lived experiences of those with SCD to those with subtle CD, to those with mild cognitive impairment, to those with Alzheimer's disease or other dementia. Naturally, given the relative homogeneity of our sample, any future studies would do well to recruit larger and more diverse samples to increase the power of their analyses and the generalizability of their findings. And finally, increasing the size and diversity of one sample may also allow for informant reports and biomarkers to be meaningfully included in analyses. We were unable to do this in this study, but given the potential for biased self-reports as neuropathology progresses, and the insensitivity of standardized neuropsychological measures, a true clinical understanding may only be reached once data from diverse sources can be accounted for, reconciled with each other, and tracked over time. All right, so That is my bit. So I'd just like to acknowledge my supervisor, my supervisory committee, Dr. Smart, Dr. Garlick, Dr. Kobayashi, the small army of RAs that I had helping with this. Of course, the Alzheimer Society of Canada, which none of this would have been possible without, and our participants, because their disclosures, their openness, their willingness to partake in this is what made it all possible. So thank you. And I'll stop sharing now, I suppose. I can work out how to do that.
Thank you, Jordan. While you navigate the stop sharing function, that we'll just start off by thanking you very much.
Oh, there we go.
Perfect. For this wonderful presentation. That was very informative and a very interesting approach to this side of research, something that's not always looked into. So I think you did a fabulous job opening our eyes to something of this caliber. And I think everyone here learned something today from listening in. So we'll now open it up to a question and answer period. Daisy, I'll hand it over to you to address any questions that have been posed in the chat box or question and answer box.
Yeah, of course. Thanks so much, Caitlin, and thanks so much, Jordan. We have quite a few questions here, so we'll go through the ones we can. And please, anybody listening right now, please feel free to put any more in as well, too, and we'll try and get to them all. So one to start off with that I think might be helpful going forwards is somebody is asking whether you could give a few examples of what executive function is, and I think particularly what executive dysfunction likely is.
Yeah, so executive function is an umbrella term. So there's a number of different things that are counted as executive functions. There's a number of different things that could be counted as executive dysfunction. So things such as being able to sequence things. So making a cup of tea, knowing that you have to grab your teacup and then grab your water and grab your tea bag and do all of that in a certain sequence. That is an aspect of executive functioning. Being able to do mental arithmetic or hold somebody's name in your mind and sort of work with that, that is executive functioning. Being able to reason through things, make decisions in sort of responsible, linear, sequential sort of way, that's executive functioning, as is monitoring how my attempts to do anything are going. So if I'm trying to get to the store, being able to track that, you know, I'm taking the right turns or how to adjust when I take a wrong turn, all of that would also fall under that.
Oh, interesting. And this person too is specifically wondering about, with so much happening digitally or online these days, whether any kind of password or that kind of online navigation might count as executive dysfunction if somebody's having trouble remembering their passwords or how to get into those accounts, if that could be included in some kind of executive dysfunction.
Yeah, that probably wouldn't be executive so much. That would be more of a memory issue and a recall issue. One of the challenges is when we've learned something new, like a password, which we haven't known for years, laying down that memory, it's a fairly shallow memory because it's new to us. And so it's likely to get lost or sort of lost amongst all of our other thoughts and things. And so digging that out again is really more of a recall challenge than an executive one.
Interesting. Thanks for that clarification. And then one of our next questions, this one is a bit of a longer one, but it's quite interesting. So they're asking about the fact that many GPs or, family physicians often don't delve into kind of identifying or, risk for dementia levels for their patients. This person is wondering how you might be able to get this kind of information to frontline support workers or healthcare providers to help them be able to identify people who may be at risk and provide those interventions, lots of the ones we're seeing with modifiable risk factors these days.
Yeah. So there's a couple of pieces to that. So one is we don't have a really clear idea yet of what qualitative risk factors might look like. We could share brochures and that sort of thing with people, and that is actually something that we have planned once we have our results more solidified. So farming that out, brochures, putting things online, letters, whatnot, even YouTube videos and things. People are doing all these blog things now. So those are all ways we can get the word out. Now, one of the challenges is, what does a GP do with that? So at the moment, the exact same recommendation somebody would make for an older adult without dementia would be the same as somebody with for the most part. Keeping your body active, keeping your exercise up, and making sure that blood keeps flowing to your brain is going to be the thing that you want to do. Eating less fat, that Mediterranean diet that people talk a lot about, that seems to be good for your brain. Keeping active, trying to learn new things, being socially engaged. So one of the challenges there is we can get the word out about what these risk factors are, but it wouldn't really modify the approach people are taking at the moment, because we don't have a whole lot of stuff in our armamentarium.
I wonder, would that be different for, I know many clinical trials these days are, like you mentioned at the beginning, trying to recruit people earlier and earlier into the disease process. Do you think that this could ever be useful in that kind of situation? I mean, perhaps in combination with those biomarkers that you're mentioning and other neuropsychological assessments to identify people really early on?
Yeah, I mean, it's challenging because right now, we don't have any evidence that we can stop dementia from happening. But what we can do is we can build cognitive reserve and physiological reserve, which is basically building up your resilience to things happening. And so when people do have good physical health, when they do have good mental health, when they do have education earlier in life, then that actually allows them to function better for longer before dementia takes hold, if it's going to take hold.
Yeah, that's really interesting. And this question might follow up on that too. Somebody is wondering if you have any plans, maybe now or in the future, to check back in with the participants who participated in these studies, maybe in a few years, to see if their cognitive function has changed in that time.
Yeah, it's a possibility. So we, in our consent forms, we did include a piece to let people let us know if they wanted to be contacted later if we do any follow-up. So we didn't have to go through the ethics process and all of that again, of course, but we could do that. And it could be something as simple as asking whether somebody has a diagnosis of any cognitive issue now. And that would give us a little bit of an understanding about how on the point or not some of our models are.
Interesting, yeah. And then some people too are wondering about maybe a bit of synthesis of your results here, about in kind of simple layman terms, if you could articulate what the biggest aha from this study was, or the biggest implication for you, particularly in this.
Okay. For me, as a clinician, I think the most interesting thing was that executive functioning is where we want to be focusing. A lot of effort and time has gone into understanding the memory profile of Alzheimer's disease, or the language profile of frontotemporal dementia, or there's all these different profiles we have for specific domains. But executive functioning is this, like I said, a really finely tuned system. And chances are, if any neurological disruption is happening in any way, that's the place we'd be picking it up earliest. And that might be sort of a transdiagnostic thing. So that was really interesting to me. I think that's sort of where we need to be focusing a lot of our efforts.
That's super interesting. And what you mentioned there too, I was wondering about. I know you're at the end, near the end of your education now, and are beginning to work clinically. Do you think any of this research has changed or will change the way you work as a clinician instead of just as a researcher?
Funnily enough, actually, I think it's the other way around. My clinical work has really informed my research approach. One of the reasons why I almost always include a qualitative component is because there is a tendency for older adults to be misheard, to feel unheard, to not even be asked about their lived experience. And I think not only is that important clinical information for us to include in our diagnosis and everything else, but it's important just to value the person walking through our door. So I think for me, the clinical piece and that human piece kind of really spoke to my research approach.
Yeah, absolutely. I was really struck by when you were mentioning the differences between SCD and subtle CD, and the idea about how people were willing to share versus were, afraid to share and felt like dementia was really threatening them at that moment. And it was making me think of some of the research that's been coming out recently about how anxiety might be increasing the rate of cognitive decline, or I feel like I've seen some specifically about conversion from mild cognitive impairment to dementia. And so I was wondering if you have any thoughts about how anxiety might be involved in an actual process there, maybe instead of a symptom, and how that might relate to the differences between SCD or subtle CD.
Right. So for us, we did have anxiety measures as well, and we saw a few flags there, right? As far as fear of aging being an anxiety index, and physiological anxiety being an index. However, these folks weren't really in that clinical range. So I think it's two different things. When somebody has really elevated anxiety, really elevated emotional distress, that has been shown to accelerate cognitive decline. That goes for depression and other things as well. So we know that. But for these people, it seemed more just, I'd rather not talk about that. And we see that a lot with the mild cognitive impairment literature, where when the word dementia comes up, people get really quiet. And when you talk about what's hard for you, they open up. So a lot of it has to do with our languaging and our approach. So we're not making salient those things that people would just rather not address head on.
Yeah, absolutely. I mean, I think that really points to how much stigma and fear there is around dementia and how that process is really scary for so many people. There's also another question here about wondering if you had looked at any, I think maybe not, but I would be curious to hear your thoughts about any age-associated hearing loss that maybe would be correlated or involved in executive function, or if it had any impact on SCD as well.
Yeah, so I'm not an expert in this. I'll put that out there right now, but there is some evidence to show that when people's hearing goes, it actually does lend itself to cognitive decline, particularly because this is a passive, if we think about sensory input as brain food, it's sort of a passive way that we're always taking in brain food, and we're cutting all of that off. So we're sort of starving our brain a little bit more than it's used to being starved. And so it definitely does lead to, more atrophy and stuff, especially in those areas that would be processing that information and integrating it with the rest of our brain. Now, again, as far as executive functioning goes, I'm not really sure. So executive functioning tends to be sort of frontal, and our hearing is more temporal generally. It's all integrated, of course, but I'm not sure about specific impacts on executive functioning.
Interesting. And then somebody is asking here, they're saying it's a bit embarrassing, but I don't think it's an embarrassing question at all. They're wondering about how someone actually can be officially diagnosed as having dementia or Alzheimer's, and what tests are actually involved in that there.
Yeah, so there's a couple different ways. I'm going to be biased because I am training to be a clinical neuropsychologist. So I would say get a neuropsychological assessment. And often that is the way that it goes. So someone will often go to their GP if there are flags raised or if they're concerned. They might do something that's a cognitive screener, which would be a simple test of maybe 10 to 15 minutes, where you do some simple activities. Most people should do fairly well on that. If they do lower than expected, then they might be referred to a clinical neuropsychologist to do a more expansive battery. And sometimes that can be 2 or 3 hours. Sometimes it can be 6 or 8 hours of testing for all sorts of different things. So that's typically how it goes. And sometimes you're asked to come back maybe 6 months or a year later to see if anything had changed. And that's when they can make the definitive diagnosis.
Yeah, of course. And then there's one clarification question here too. If somebody is asking if you could repeat the difference between SCD and subtle CD again.
Yeah, I gotta say, I hate that these terms sound almost exactly the same. And I was going to apologize for it, and then I realized, I didn't do it, so I'm not going to apologize for someone else. But so SCD, subjective cognitive decline, is when people are really worried about their thinking abilities. They're noticing changes. They're probably telling people about those changes. But when we do these tests, they're exactly where we would expect. And sometimes, depending on the person, maybe even a little higher than we'd expect. So there's no sense of any slipping cognition as far as our tests can tell. Now I'm getting mixed up. Subtle cognitive decline is where people may or may not be aware of anything changing. But on our tests, they're scoring a little bit below what we would expect for them given their age and their education. They're still within that normal range, but they're sort of on the lower end of that normal range.
Interesting. Okay, that's great. And then I also do notice quite a few people in the chat here wondering about participating in research. So I think that's great. Your presentation has definitely made people interested in participating. Excited about that. Which I can say, I would direct you all to the Alzheimer Society research portal, which is a national research portal. That can help match you to studies, or also you can connect with your local Alzheimer's Society, so your provincial one, which might have some more information about who's recruiting right now. But Jordan, I'm wondering, are you taking part in any studies right now that are looking for participants? Because you definitely have people here who are interested in it.
That's lovely. Unfortunately, I'm not at the moment. I'm finishing up my clinical residency, so I'm just really, we're working on a couple of studies that are based on this project at the moment. So that'll take the next year or so, maybe more, to spin out. So unfortunately, no, we're not recruiting anyone at the moment for any of our efforts.
Very understandable. But yeah, I think it's really great if anybody's interested. I think we would all really encourage you to reach out and try and get connected. Oh, yeah, I see somebody's asking for a link to the National Research Portal. Maybe Caitlin could put that in there for a second. I think it's so meaningful, as Jordan, as you said, you know, especially those qualitative concerns, and being able to actually share what your experiences is such a valuable and important part of learning more about dementia.
Definitely.
Yeah, and so those are all our questions for today. So I'll pass this back over to Caitlin now to finish anything up or to do any of that. But thank you so much, Jordan. That was such an interesting presentation this morning.
Thank you, Daisy and Jordan. That was an excellent question and answer period. I think we really touched on a lot of the different points of your presentation, but also were inspired to go in new directions and inspire people to take part in research. I think that's always a great results to come from something like this. So just up on the screen, you'll see the two places where today's presentation will be posted. So it is recorded. And if you're an Alzheimer's Society staff member, you can find this recording posted to our connection page. And if you're an audience member from the public, you can find this directly on the Alzheimer's Society Canada website, ASRP Exchange page. So both of those are linked there on the screen for you. And I've also included our PSP, which stands for Provincial Support Program, email address. So if you have any lingering questions that weren't answered today, you can always ask those through that email address. And then finally, I'd like to just introduce a presentation that will be taking place on May 14th. So this is our next ASRP Exchange presentation. This will be led by Dr. Lillian Hung on May 14th at 12 p.m. Eastern Standard Time. Dr. Lillian Hung is a Quality of Life Postdoctoral Award recipient, and her research focuses on technologies in hospital care for individuals living with dementia. And the registration link is provided at the bottom of the slide. To just circulate back to today's presentation, thank you once again, Jordan, for a fabulous job. I really do find your research so interesting, and I really appreciate the lived experience aspect that you've pulled into this type of work and really seeing the person behind the studies. I think you did a great job pulling attention to that. So I think we will conclude today's presentation here, and thank you all for posing your questions and comments. Thank you, Daisy, and thank you, Jordan.
Thank you, everyone.